delivery at 39 weeks. What is her GTPAL? So if we think, looks like she's had 2 pregnancies, 39 weeks, we'd consider that a term pregnancy. So B, right? Yeah, right. So G2, P. So the first one after P is your term. The next one would be preterm. Abortus is 1. And then she has 1 living. Very good. So the answer is B. Yep, that's correct. All right, and now she comes in a few months later and she's pregnant. She's in for her prenatal visit. What should her initial screening include? So think about triple screen, quad screen. Do we get an ultrasound? When do we do Leopold maneuvers? B, yep, ultrasound to establish gestational age. That's really important. We'll go by the last menstrual period initially, but the best way to establish gestational age is a first trimester ultrasound. Remember, second trimester, there's too many cofactors or confounders that can impact baby's weight and how baby's growing. So we're going to go with that ultrasound to establish gestational age. Very good. When I think about maternal physiology during pregnancy, really every system in mom's body is going to be affected. Most of these changes are going to be physiological in nature and basically an adaptation process so that the body of a pregnant female can accommodate for that growing embryo and then ultimately the growing fetus. Okay? One obvious factor that affects the maternal physiology is the mass effect of the growing fetus and the ramifications that's going to place on the cardiovascular system, on the pulmonary system, GI, and even endocrine system. As that placenta develops and as the uterus enlarges, these organs are going to receive a greater proportion of blood flow to help support that growing fetus. Other organs like the kidneys, they're going to receive more blood to help filter waste from not just mom, but from the fetus as well. There's hormonal upregulations, and that has downstream effects, affects a lot of systems, and affects both vascular tone and connective tissue. These hormones, they could also cause water retention. So later on in pregnancy, mom can have increased lower extremity swelling, and it can cause some changes in the serum electrolyte. Okay? Luckily, for the most part, mom's physiology is going to return to normal non-pregnant state pretty soon after delivery, usually within the first 6 to 8 weeks after delivery. But we're going to talk about some specific changes that we might see in different systems of the body. Let's talk about cardiovascular changes that we may see first. So the cardiovascular changes are really mechanisms that the body has adapted again to meet the increased metabolic demands of mom and of the fetus to ensure that we have adequate circulation to the uterus and to the placenta, which allows for appropriate fetal growth and fetal development. Now, as other organs are enlarging because of the growing fetus, the heart then gets displaced upwards a little bit and leftward a little bit due to an elevation in the diaphragm. So we're not going to see that early on. We're going to see that as the fetus is growing. Because we have that slight displacement upward and to the left, we may actually see on chest x-ray an enlarged cardiac silhouette. The heart itself isn't really enlarged, but on chest x-ray it may appear enlarged. We may also see left axis deviation, a new left axis deviation on EKG. So those things you want to be mindful of if a person comes in with chest pain or shortness of breath and you're getting a chest x-ray, EKG, you may see those changes. that really are new for the patient, but it's a part of the growing fetus and the displacement of the organs. Many of the cardiac sounds are modified as well, and that's due to increase in maternal heart rate, due to increase in cardiac output as well. After the first trimester, the first heart sound is typically a little bit louder. There's this exaggerated split of the first heart sound, the best one. You can have an ejection systolic flow murmur in about 90% of patients. A third heart sound is detected in about 80%. We can have a diastolic flow murmur, about 20% of patients. And about 10%, again, further on in pregnancy, might have this continuous flow murmur, and that's really due to increased vasculature of the breast tissue. The increased estrogen and progesterone throughout the pregnancy is going to cause a decrease in systemic vascular resistance. In turn, that's going to affect the blood pressure. We have a slight decrease in blood pressure, but we also have a change in the heart rate, which will increase a little bit, and cardiac output, again, is going to increase by about 30 to 50%. Right? When we look at the resting heart rate is going to increase by about 10 beats, and I would know that. Normally, this is going to be occur starting around 12 to 16 weeks. So 10 beats per minute is not unusual. Between 10 and 20 weeks, there's an increase in overall blood volume, which is going to increase preload. And then maternal posture. Maternal posture is going to affect how the body responds to these changes. So like hemodynamics, if mom is lying supine on her back, we're going to increase pressure on that vena cava, which leads to things like dizziness and hypotension when they stand up, lower extremity edema. So when we look at these line graphs on the side, they're about maternal posture. So red is mom is lying supine, yellow is mom lying on her side, and then blue is mom is sitting. So heart rate, if someone is sitting versus lying down, is going to change. It's going to be a little bit higher. Stroke volume and cardiac output as well. All of those change depending on the maternal position. The blood pressure in pregnancy is going to be more of a U-shaped. So it starts normal, then it goes to its lowest around 26 weeks, and then it's going to return to that baseline closer to term. So we talked about that earlier, that if someone comes in and they have a blood pressure of 140 over 90, that's really something to be concerned about, because in general, we expect the blood pressure to be a little bit low on the lower range and have even a dip around that 26 week mark. There's just a shallow depression, not really anything drastic, but again, more on the hypotensive or lower blood pressure than the hypertensive side. That enlarging uterus is going to displace and compress the iliac veins. It's going to affect the inferior vena cava and then the aorta as well. So ultimately, you may see some stasis, and that puts these women at increased risk for developing blood clots and lower extremity swelling. Usually that lower extremity swelling is something, again, that we see at the end of the day, so that's not unusual at all. When we have compression of these great vessels, that leads to increased pelvic pressure. That can result in varicose veins of the legs, the vulva, may cause hemorrhoids as well, which we'll talk about a little bit later. Up to about 10% of these patients can have what they call supine hypotensive syndrome. Here we have a significant decrease in blood pressure, and that's associated with nausea, dizziness, and even syncope. And that results from compression of those great vessels. Usually, that will result if mom has been lying supine. I went to lay down, I fell asleep, I was laying on my back, I stood up and I almost passed out, or I did pass out. So in general, we're going to recommend that mom lay on her left side, right? Especially the further along they get in pregnancy. And that helps alleviate the pressure on those great vessels, help reduce some of those signs and symptoms they can have. compression of the great vessels. All right, so that's all I want you to know for the cardiovascular system. Let's talk about some changes that we may see in the respiratory system. But as that pregnancy progresses and the fetus enlarges, there's about anywhere from 4 to 5 centimeter elevation of the diaphragm. Okay? The thorax itself is going to compensate by expanding about 6 centimeters in both the anterior, posterior, and the transverse or the lateral diameters. Okay? So it's going to go out and it's going to be wider. So long on this, we talk about lateral, we talk about left to right, and then anterior to posterior, we're going to have changes. Overall, because the body is compensating for that, the lung capacity is unchanged. And I would know that. Total lung capacity is unchanged because of the chest wall expansion. It's allowing for the lungs to expand and contract normally. There is an increase in metabolic rate. This leads to an increase in oxygen demand. Okay, the tidal volume, the minute volume, that rate increases, and that helps meet this increase in oxygen demand. Okay, so again, tidal volume and minute volume rate increases to help mom meet that increase in oxygen demand. I would know that. Okay. Respiratory rate essentially unchanged. So if these patients are coming in, they've got a respiratory rate of 24. That is abnormal. That is increased because we shouldn't really see much of a change in the respiratory rate. A lot of times these women will experience hyperventilation during pregnancy. So we have an increase in pH, we have a decrease in PCO2. And it's thought that this is related to an increase in carbon dioxide production, increase in respiratory drive, all caused by an increase in progesterone throughout the pregnancy. This hyperventilation can result in a mild respiratory alkalosis. So again, someone comes in, being seen for something like shortness of breath, maybe the VBG is done, and on that VBG we may see that they're slightly alkali. Okay, that is not unusual. It's called respiratory alkalosis of pregnancy, completely normal, and this is typically seen further along in pregnancy, more in that second trimester of pregnancy. That's it for our respiratory system. So I pointed out a couple of things I would know with that. Let's talk about the changes we will see in the GI system. So the stomach and the intestines, they're going to undergo changes during pregnancy. Remember that everything is moving. The heart is moving to the left and upward. Lungs are moving out. The GI tract is moving up as well because of the growing fetus. And because of that growing fetus, the other thing that happens, we have a lot of pressure on the GI tract from below. It's pushing everything up. From that pressure, we're going to have a decrease in esophageal sphincter tone, decrease in intraesophageal pressure as well, along with a decrease in esophageal peristalsis. Okay? All of this, plus increased gastric pressure, leads to mom having increase in reflux and GERD. And this typically happens pretty early on in pregnancy. Oftentimes, we encourage mom to have small, frequent meals, avoid any trigger foods, increase the head of the bed, try not to eat more towards bedtime, and then they can take oral antacids or even H2 blockers or PPIs. Those are safe in pregnancy. The gastric emptying time essentially remains unchanged. Okay, so that means that people are digesting food at a normal rate, except probably around the time of labor, where the body's in crisis mode, and then the gastric emptying time may actually be prolonged. Now, it's important to note that the appendix is moving and is displaced as well, often up a little bit and out to the side. So sometimes even all the way out to the flank, especially in a multi-gravid uterus, right? And the reason why that's important to know is because when mom comes in complaining of abdominal pain, we want to think that the appendix may be all the way out by the flank, so she may actually have appendicitis. It could be mistaken for like a kidney stone or pyelonephritis, but if she's not having urinary symptoms, you want to keep appendicitis on your radar and on your differential for a female pregnant patient that has flank pain. Pregnant women can get cholecystitis among other GI emergencies. They actually have a higher propensity for gallstone formation because the gallbladder is not contracting as it should. There's an increase in residual volume and it's not emptying as well as it normally would. There's also increase in intrahepatic cholestasis, right? And this is due to retained bile salts as the longer the pregnancy goes on. These patients can then present with like a jaundice, a pruritus, which is severe itchiness, and this is known as pruritus gravidarum, right? So think about jaundice, severe itching, but no rash. This is due to increased bile salts. It's called pruritus gravidarum, increase in intrahepatic cholestasis. Okay, so I would remember that. Liver, we might have a slight increase in size, but really nothing significant. Okay? There is a little bit more blood flow going to the liver though. So what we may see some mild changes in those liver enzymes. I really wouldn't spend a lot of time looking at those changes in the liver enzymes. Just know that we do have a slight decrease in our AST and ALT, slight decrease in bilirubin, but I wouldn't memorize that. That liver, I wouldn't memorize that for the test. Just know that for real life stuff. Nausea and vomiting, really common during pregnancy. We say morning sickness, but really we know that this can occur at any time during the day, but it does typically occur more in the mornings. The bad news is this affects about 3 out of every 4 women. The good news is oftentimes it's just that, just nausea, vomiting. It's not significant enough for them to have electrolyte derangements and require admission to the hospital. Okay, but what we think the primary cause of this is really linked to increase in HSG or HCG. Okay? We know that early on in pregnancy, HCG levels are really high, and then when we get to the end of that first trimester, we have a slight decrease in HCG levels, and then the HCG is going to plateau out. So these patients tend to have more of that nausea and vomiting throughout that first trimester and then early second trimester. And then a lot of times this resolves or at least improves significantly. Again, seldom does this result in any sort of electrolyte disturbance. Sometimes these patients do need IV fluids, and sometimes we'll have to talk to them about, again, changing their diet a little bit, trying to avoid any foods that are triggering the nausea, vomiting, frequent small meals. We also think about pyridoxine or B6, diphenhydramine, Unisom, which I don't have on here, but Unisom is very important. So we'll prescribe that very early on in pregnancy for these patients that are having nausea and vomiting. We can give antiemetics. Ondansetron would be the primary one, but that is not first line. That should be considered only if they've failed the pyridoxine, the diphenhydramine, which is Benadryl, or in the Unisom. And so usually we'll do pyridoxine and Unisom together, and then they can take the diphenhydramine. That's completely safe in pregnancy. And then if they come back because it's not working, then that would be the time that we would consider antiemetics. We've got a lot of kidney changes, a lot of renal changes that we're going to talk about. We're going to have the increase in cardiac output. That causes an increase in renal blood flow. That's going to increase the GFR by about 50 to 60%. Okay, so we also have an increase in the kidney size. So the kidney itself actually increases in size. Or the kidneys themselves actually increase in size by about 1 centimeter. Okay, progesterone is going to affect the urinary collecting system. It causes relaxation of the ureter. So we might see hydroureter if the patient comes in with flank pain and trying to assess if they have a kidney stone. We actually may see, as a part of pregnancy, we may see hydroureter. Okay, we can also have relaxation of the muscles of the bladder. Both of these changes can cause urinary stasis that predisposes these patients for urinary tract infections, and then ultimately they may even get pyelonephritis. So we want to keep that in mind. Because we have that increase in renal blood flow, we also have hyperfiltration, and ultimately we may see a decrease in serum creatinine because of that. Okay, so decrease in serum creatinine, but increase in GFR, increase in the kidney size. Okay? All right, that's it for our kidneys. Let's talk about some metabolic changes, or several of these we'll talk about. So we should think that, women's metabolic rate is certainly going to increase during pregnancy, and we need increase in our nutrition to support that. Okay? So that's why food needs and nutrition has to increase. And we talk about that 300 kilocalories a day as a normal amount of increase, a normal amount for mom to intake throughout the pregnancy. Weight gain on average, recommend 25 to 35 pounds for these patients, and usually 28 pounds is kind of our normal, as long as they have a normal BMI. We talked about this previously. You need to know these weight gain parameters, okay, especially the normal weight gain parameters. Remember, weight gain isn't just mom eating, it's a lot of other things. It's baby growing, it's increased breast tissue, we got fluid retention, we have increased blood volume as well. This is more of a dilutional hypervolemia, but overall we have an increase in blood volume. Oops. And water retention is normal. We've got swelling of the lower extremities from that water retention, mom feeling like she's bloated all the time. All of that is normal. Mom's holding on to almost 4 liters of extra fluid. That's thanks to the baby, the placenta, the amniotic fluid. As that blood volume increases, the breast size increases, so mom will retain even more water throughout the pregnancy. Most of these patients will have edema, especially at the end of the day, and that again is in part due to that 4+ liters of fluid, and also due to the uterine position against the vena cava, causing a partial occlusion, even if mom is not lying on her back. Depending on, that gravidutus is going to push on that vasculature. In pregnancy in general, we have a decrease in interstitial colloid osmotic pressure. Okay, we have fluid that leaks out of the capillaries, and that's going to be a causative agent for that edema as well, especially later on in pregnancy. And we've got changes in the way that the body metabolizes carbohydrates. Okay? And that's to ensure that we have this continuous supply of nutrients to the growing fetus, despite mom eating intermittently. So yes, mom does typically eat more often, but she's not eating every second of the day. So the body has to hold on to those carbohydrates so they can slowly release nutrients to the growing fetus. Okay? So a normal pregnancy is characterized by this mild fasting hypoglycemia, meaning when mom's not eating, there's a little bit of a dip in the blood glucose. We have this prolonged hyperglycemia after eating. So after mom eats, we want those blood glucose to stay up to then compensate for the time she's not eating. So again, allows that baby to have continuous nutrition. And then we have hyperinsulinemia, so excess levels of insulin circulating in the blood. So this glucose metabolism, again, the way this works allows for that constant supply or adequate supply of glucose and nutrients to the fetus. We should recommend to pregnant patients that they do not fast because this puts us in a ketosis. And most of the time, these people are already undergoing an insulin resistance in a mild form due to the pregnancy. So we want to make sure that we talk to them about frequent small meals so they have that constant supply of blood glucose for the baby and to prevent this ketosis. Okay? If we teach the body to use ketones instead of glucose, it really doesn't work well for growing babies, okay? Because that glucose from the carbohydrates, that's the primary energy source for baby's growth and appropriate development. So no fasting during pregnancy. The electrolyte and mineral metabolism also are going to change. Because we have that increase in GFR, we have increased resorption, and so we will see a slightly lower sodium, slightly lower potassium as well. Magnesium tends to be a little bit lower. Um, there's an increased production of iodide, and that is to support the baby's developing thyroid. This is especially seen in kind of the second half of pregnancy. Because the kidneys themselves are physically larger and we have that increase of GFR by about 50%, more iodide is being excreted. So we have this increased need, which is why during that second half of pregnancy, we have an increase in production. There's also an increased need for iron, right, to help prevent anemia in these patients. That's why our prenatal vitamins are so chock full of iron supplementation, but sometimes these patients need additional iron on top of the prenatal vitamins or prenatal vitamins that have higher content of iron. The fetus is going to take calcium and vitamin D from mom, and this is to develop the baby skeleton in their bone. Right? So mom needs to increase the amount of calcium and vitamin D. We've talked about that. They want to helps avoid these depleted calcium stores. So 1,000 to 1,300 milligrams of vitamin calcium is recommended per day. So you want to remember that. And calcium, it's nice to have it because you can get it with this vitamin D3 kind of built into it. Again, make sure you understand that increase in that calcium and the amount that they need to increase. Okay, we've got skin changes that occur. Hyperpigmentation of the skin is seen in the majority of pregnant women. We're not really sure of the exact cause, but a lot of the research out there believe that there's melanocyte stimulating hormone that is created by the placenta, and that causes melanin to rise during pregnancy. So these skin changes tend to be more accentuated in women of darker skin color. So they may come in, they have this midline hyperpigmentation in the abdomen. This is called linea nigra. They may have hyperpigmentation of the face. We call it the mask of pregnancy, or called chloasma. The areolas tend to expand and they tend to get darker. Genital skin can also become darker. Typically, these changes resolve almost immediately, resolve after delivery, but oftentimes it's going to take again, 6 to 8 and sometimes even 12 weeks or so, sometimes even a little bit longer for these skin changes um, to improve. Sometimes I've seen people have that linea nigra. It does get better. It's not so hyperpigmented, but even after a first pregnancy, they still have a slight line for the remainder for the, for the remainder of their life. So we do have improvement, but doesn't always go completely away. So there's a mask of pregnancy there in a dark-skinned person. And then this is a mask of pregnancy in a lighter skinned person. We can just see that hyperpigmentation on the cheeks. And then this lady also has a little bit on her chin area. Right, so in addition to the hyperpigmentation, there's going to be some vascular changes that may occur. Pregnancy overall is an increased vascularity state, so the skin is going to be affected. You can have what's called telangiectasias or spider angiomas. We can see that in that top picture. So it's kind of this small reddish, looks like little spiders that branch out. Sometimes, again, these are referred to as vascular spiders, oftentimes seen on the face, neck, chest, and arm areas. There are some women that get palmar erythema, which is what we see in that bottom picture. This is due to increase in estrogen and because women are trying to dissipate excess heat because there's this increased metabolic state due to the pregnancy. So the heat is escaping through the vascularity in your hand. I haven't seen that a tremendous amount, but I've definitely heard people talking about it. And then striae gravidarum, also known as the dreaded stretch marks, they're definitely going to develop in the majority of women. Okay? So you'll see these typically on the breasts and upper thighs as well as the abdominal area. In multiparous women, you can actually see striae that developed in previous pregnancies. They develop inside the red marks of the current pregnancy, but the older striae, the older stretch marks are more silvery in appearance, as opposed to the reddish appearance that's seen in the current pregnancy. Women that have excessive weight gain, if they have a family history, if they're younger, maternal age, they're at higher risk of increase in striae. Unfortunately, there's no real creams or pills that can prevent this from happening, despite what you see on the internet, despite what you see on the TV. Most people are going to get these stretch marks, and there's not a lot of creams that are going to prevent them from happening. Certainly, some of those creams can reduce the stretch marks, but preventing it is very difficult. The good thing, there's no long-term complications. There's really nothing. It's not going to affect the pregnancy. Just some people think it's unsightly. They don't really like the appearance of it, but keep in mind these do improve significantly after delivery. All right, so musculoskeletal system. Musculoskeletal system. You can imagine we've got quite a few changes in the musculoskeletal system. As that pregnancy, um, as a mom becomes more pregnant, the more gravid uterus, they have to start, they have to have these musculoskeletal changes to accommodate the developing fetus, that growing fetus. So oftentimes, these pregnant patients will have a progressive lordosis, and that's an increase in the lumbar curvature. And this curvature, this lordosis, is going to allow for redistribution of the center of mass. So mom is not walking and falling forward all the time. It allows us to kind of redistribute the weight of the baby, the growing baby. With that lordosis, the rest of the spine has to kind of accommodate as well. So there often is a overflexion of the neck. The shoulders kind of slump over a little bit as well. So patients may come in complaining of upper extremity numbness or weakness or pain, and that's all due to the accommodation of not only the lordosis, that's going to cause low back pain, but the upper spine, kind of a kyphosis to accommodate for that lordosis. There's increase in the mobility and laxity of the joints. Okay, that's good because that accommodates for the enlarged fetus, but this also causes discomfort for mom. Okay? Good thing is after delivery of the baby, those joints begin to strengthen really almost immediately and then return to pretty much baseline in about 3 to 5 months postpartum period. Right, back pain. So back pain, gosh, yeah, about 70% of women are going to come in complaining of back pain, or maybe they don't come in, but they'll complain to somebody about it. Because you got back, again, you have that progressive lordosis, and so that's going to really affect their gait and cause significant discomfort in the back. Um, Oftentimes, this is seen more in the latter portion of the pregnancy, that's the second or third trimester. There's not a tremendous amount to do about it. This is the body's way of accommodating, but we could recommend maybe a pillow while they're sitting that stabilizes the back braces, but there's really no evidence that back braces tend to work. So it depends on if how uncomfortable mom is, and if they're able to get one to accommodate the gravid uterus as well. Near term, we got to be careful though, because these patients are coming in, they're complaining of pretty significant back pain. We want to make sure that these actually aren't contractions that are masquerading as back pain, especially if pain is coming in waves. And your patient comes in and is like, yeah, I don't know, it's really weird. Like, I'm having this back pain like every 3 to 5 minutes. Okay, that's probably not back pain, that's probably contractions. So you gotta be careful with that. In general, we want to avoid NSAIDs in pregnancy, but acetaminophen is okay. The safety data on muscle relaxers in pregnancy is limited. So the best thing to do is encourage strengthening, encourage stretching. They can do light exercise, physical therapy if needed as well. And this is where our prenatal, preconception counseling comes in. We want to have really strong abdominal muscles because they support the back muscles. So if they go into a pregnancy with weaker abdominal muscles, those patients are a lot more likely to have back pain. But if they do have it, then acetaminophen, stretching and strengthening are what's recommended. Another part of those musculoskeletal changes is something called round ligament pain. This typically occurs, oh gosh, early in that second trimester. So I've seen it between 14 and 18 weeks or so. If you look at the picture, it'll show you kind of the area, so it's kind of the sides of the abdomen, but the suprapubic area as well. And that's where our round ligaments are located. So as the uterus is growing, these ligaments are going to stretch to support the growing uterus, and that tends to be fairly uncomfortable. And in these patients, I've seen them come in bent over, crying. I mean, I really thought they were going into labor at 16 weeks because they were so incredibly uncomfortable, or they had a ruptured appendix or something. But it really is due to round ligament pain. So pay attention to where they're complaining of the pain. It doesn't always have to be bilateral. They could have one side or another. Oftentimes the right side is affected more than the left, which is also concerning because if they still have an appendix, then again, we have to think about appendicitis as a cause. So treatment for this really is reassurance. We can recommend stretching exercises. They can use a heating pad or warm bath. And then we can do some slight activity modifications like decreased lifting, but really bed rest is not recommended. Remember, bed rest, these patients are already at risk for DVTs and PEs. So bed rest increases venous stasis, so it increases the risk even more of DVTs and PE. So just kind of a slight modification. If those things don't work, we can give analgesics, but but usually that's not necessary. If it is, then acetaminophen is recommended. Again, no NSAIDs in pregnancy. Okay, we did talk about linea nigra, which is that darkening of the skin down the middle of the abdomen, or the hyperpigmentation. Well, here, this is different. Okay, this is something, yes, down the middle of the abdomen, but this is really a ventral hernia formation. It's called diastasis recti, and it affects the abdominal wall, where the rectus muscles are separate due to too much pressure, again, due to the expanding fetus, expanding pregnancy. So there's actually a gap that develops in between the rectus muscles. Unfortunately, this is one of the things that does not go away after pregnancy. Okay? So these women, to get this fixed, oftentimes will need operative repair for this hernia. Okay? We can see in that first picture to the left, the patient is laying down, not really putting any increase in intra-abdominal pressure. And then the second picture, they're doing like a partial sit-up up, and you can see with that ventral hernia, or that diastasis recti is very apparent. We have a large hernia that is down the middle of the abdomen. Now, if you happen to be seeing these patients and they're coming in and they're asking for a consult, or sorry, a referral, to get this fixed, you're going to have to be a little bit clever in your wording, because this often isn't covered by insurance. They feel like this is cosmetic, and cosmetic procedures are not covered by insurance. So, saying that this causes discomfort, or something like that may need to be placed in the referral for your wording in order to help get these fixed. We've got GU changes that occur. So sometimes on examination of a pregnant female, we may see a cervix that looks like this. Now this cervix, if you don't know, looks abnormal. It's very blue. The normal cervix is more of a light pink in color, but this is very blue. And if you touch this, it's very soft. Okay? This is all due to changes from increased vascularity. This is called Chadwick's sign. This is not evidence of hemorrhage anywhere. We don't need any lab. We don't need any pelvic studies. We don't need any swab. It's a normal change in pregnancy. And you won't see this in all women. It just happens in some women. Okay? Then later on in pregnancy, as that cervix is preparing for labor, we also see some changes. Okay? The connective tissue of the cervix starts remodeling. Okay? It's more filled, the cervix itself is more filled with water, and that allows that cervix to thin and to dilate in all response to these hormonal changes, again, as that body is preparing for labor. But this bluish tinge, you may see that even, in that later first trimester and second trimester, as early as that time period. Uh, Increased progesterone during pregnancy is going to cause thickening of the cervical mucus. Okay, that thickened mucus is going to create a mucus plug between the internal os and the external os. Okay, and what that does is that actually helps prevent or fight against infection from getting up into the uterus and around the amniotic sac. Okay? Sometimes around closer to labor, as that cervix is thinning and dilating, mom will lose this mucus plug. So they'll have oftentimes coming in, may happen while they're there in labor, but they'll have this large amount of mucus that just comes out of the vagina. We may see it in the vaginal vault. So it's that mucus plug that we're seeing. And again, it's protective. It's protective to help prevent infection, but that at the time of labor, as things are changing, the cervix is dilating and thinning, that certain mucus plug is going to be lost in preparation for labor. Okay? Another thing that we may see earlier in pregnancy is something called cervical ectropion. Okay, cervical ectropion. And what it is the cervix itself actually comes, was almost protruding out of the vagina. Okay, so normally we place a speculum into the vaginal vault, and we've got to go in fairly deeply with the speculum to be able to see the cervix. Well, this is a cervix that is coming, it's coming more external, so all you have to do is really just put the speculum in slightly, and you'll see the cervix right there in the speculum. Okay? And again, this is all related to increase in progesterone, estrogen, and these changes that we can see throughout the pregnancy. This will resolve after the pregnancy, after the uterus gets back to normal size. The cervix will also return to normal. Let's see here. By about 13 weeks, remember at 12 weeks, the uterine fundus is at the pubic symphysis. So at 13 weeks, the uterus is going to be above the pubic symphysis and it's starting to climb out of that bony housing of the pelvis. The uterus then no longer has the bony protection it had earlier on. And so that puts mom and baby at risk if there's any sort of abdominal trauma, since the protection of that bony housing is now lost. Okay, and as I said earlier, that gravid uterus is going to start displacing other organs. Okay, heart, liver, intestines. As that uterus moves up, it's going to rotate slightly to the right. Okay, we're going to have connective tissue, and the abdominal tissue is now starting to support or be the main supporters of that growing baby. So there's going to be increased abdominal pressure, increased abdominal discomfort as that baby is growing. Again, when mom lies supine on with that gravid uterus, you have that increased pressure in those great vessels, and that causes a decrease in decrease in blood pressure, venous stasis, low extremity swelling. So we want to make sure that we talk to mom about lying on the left side. Okay? That way we can help decrease any sort of complications that mom's may have from the compression on those great vessels. All right, let's take a break, and then when we come back, we'll start off with slide 41. Finish this up. We have 20, maybe 19 more slides to go. So the uterus itself is designed to undergo contractions, even early on in pregnancy. Earlier on in pregnancy, when they have these contractions, are typically Braxton Hicks contractions. So they're irregular. They're not progressive. They're not associated with cervical change. We think of this as a uterus practicing its contractility. It's preparing for labor by practicing for labor. Again, these are non-progressive, non-rhythmic. They're low in pressure, contraction pressure, and they tend to be infrequent until we get towards the end of pregnancy, when they can occur about every 10 to 20 minutes or so. And that's still not very frequent because we consider like every 3 to 5 minutes frequent. These are false contractions, but they can cause discomfort, and some people will think that they're in labor, but again, no cervical change, no regularity to the contractions that would indicate, in fact, that they are these are regular or normal contractions that are occurring. So false contractions are Braxton Hicks, and there's no cervical change associated with them. Vaginal tissue in the perineum, they will undergo changes as well. The vascularity increases, the muscle, and the skin in this area, and it can look like a kind of a bluish color, like the same thing we talked about with the cervix. This vascularity can also cause softening of the connective tissue. The vaginal walls, they undergo loosening while the smooth muscle will actually hypertrophy. It's got a lot more estrogen. So if we compare that with someone maybe that is menopausal or postmenopausal, where they have atrophy due to decrease in estrogen, now you have an increase in estrogen. So the smooth muscle thickens a little bit. There's also often increase in lactic acid production. And candidiasis loves an acidic environment. So pregnant patients are at increased risk for vulvovaginitis, vulval vaginal candidiasis as well. And again, this is from the increase in lactic acid production, but also from hormonal changes and increasing vaginal glycogen stores as well. All right, we've got vascular changes, of course, that occur. We talked about that in skin already, but other things that can occur is varicosities. Early on, we said compression of the iliac vessels, and the indicator we can get varicosities. But these are the varicosities that we see, but we can have that from the growing uterus and the increase in lower extremity venous pressure. Patients typically have to, because they're but women that are pregnant typically have to stand throughout the day. So that's going to exacerbate and put them at risk for varicosities. Varicosities, we know, are very common in the legs, but for pregnant patients, they can also get vulvar varicosities in or upper thigh varicosities, which are a little bit abnormal outside of pregnancy. A lot of times these varicosities are unsightly, sometimes they're uncomfortable. Rarely, though, do we have any sort of significant blood loss that is associated with these. You can get, these can bleed if there's an overlying laceration or injury to these vessels, and they can bleed pretty significantly, but usually just direct pressure for 10 to 15 minutes stops the bleeding. So we talk to our patients about leg elevation, especially at the end of the day. They use elastic stockings for management of their signs and symptoms for leg varicosities. And then the bottom picture here, this lady has a purple outfit on. So I really enjoy teaching this class around the time of Christmas because I tell the people, I'll tell the students if they have a pregnant spouse at home, this would be a really nice Christmas gift. This is a vulvar varicosity supporter or vulvar supporter to decrease varicosities. You can buy it online, but essentially just a support belt, if you will, to help reduce the chance of vulvar varicosities. So although I'm sure a pregnant spouse would not necessarily appreciate this as a Christmas gift, once you explain what it could prevent, then you probably, initially you're in the doghouse, but you'll probably be back in the main house if you just explain, hey, look, but look what it will do. So I don't know that I'm going to buy that, but I definitely know people that have it. Otherwise, elevation and Ted Hose type thing. Another varicosity that we can see in pregnancy is the hemorrhoid. Okay, affects about 40% pregnant women, and I will tell you, it's probably even more than that. The majority of pregnant women will get hemorrhoids to some degree. These are painful, there's a lot of swelling, they have a lot of itching associated with them. Unfortunately, that's a tremendous amount to do. What we can do, remember that iron supplementation causes constipation. Constipation causes vulvar varicosities or hemorrhoids. And so we can treat their constipation, make sure they're on, the doctor said sodium. If they do get the hemorrhoids, we can get topical anesthetics, topical preparation aids. So they can do sitz baths. We got stool softens we talked about. And then occasionally, these hemorrhoids will be thrombosed. And you'll know they're thrombosed because instead of looking like that light pinkish color, they look like a big, giant purple grape, okay? Because they essentially are kind of necrosing, blood, dried blood inside there, but not only dried blood, but if you cut those open, those tend to bleed significantly. So you can incise a thrombosed hemorrhage and you can remove the clot, but only if you've been taught how to do it. Otherwise, you got to be prepared for a significant amount of bleeding associated with these. Okay, so talk to your patients about preventing constipation, doing these sitz baths, and then topical medication that tends to work okay. Okay, we've got changes in the endocrine system. Okay? We've got this is all really just to assist in fetal survival and to prepare mom for labor. So the hypothalamus is going to receive positive and negative feedback from the pituitary and the ovaries that increases your estrogen and progesterone. The pituitary gland itself increases in size due to increased vascularity. You got increased estrogen, and there's hyperplasia of the lactotroph cells. Prolactin levels tend to increase by about 10 times normal. Okay, so you got to know that, right? Someone comes in, they've got this weird headache, and you're like, oh my God, I think you have prolactinoma. Now, prolactinoma is you're talking about 100 times normal, but just know 10 times normal, that's significant. You're like, why is your prolactin level so high? Well, it's normal in pregnancy. Okay, prolactin levels will drop off after delivery. Even in women who are breastfeeding, their prolactin levels will go back down pretty quickly after delivery. But we have problems with the thyroid. Okay, so the thyroid is going to enlarge a little bit, and that's due to an increase in HCG and estrogen. Interestingly, HCG and TSH are structurally similar. So early on in pregnancy, you have the elevation in HCG that results in thyroid stimulation. So increases in estrogen elevation throughout the pregnancy result in increased thyroid, increase hepatic production of thyroid binding globulin. We got T3 and T4, they tend to bind to the thyroid globulin, and this causes more TSH to be released when the anti-pituitary. Free T3 and T4 levels essentially remain unchanged, but total T3 and T4 levels will increase. So the thyroid gland increases, we've got an increase in T3, T4, and all of that is really important for neural development, for fetal neural development. Okay, and then we've got the parathyroid. Okay? The parathyroid, we have increase in serum calcium levels, oftentimes from supplements. Okay, and we've got a change or usually a decrease in the serum PTH level because strangely there's an inverse relationship between PTH and calcium and magnesium. So PTH levels will decrease early in pregnancy and then normalize in the middle of pregnancy. And that's really important because PTH is needed, calcium is needed for fetal skeletal development. So inverse relationship between parathyroid and calcium, but we need that increase in calcium again for fetal skeletal development. We have we have progressive insulin resistance, and that's in order to divert glucose towards the growing fetus. To compensate for that, the pancreatic beta cells must increase the amount of insulin that's produced. If we don't do that, the body doesn't do that, or failure of those normal adaptive responses, that can lead to gestational diabetes. Okay? So if we don't have that appropriate response from the beta cells, um, that increases the risk of gestational diabetes and ultimately the cause of gestational diabetes. The adrenal glands, they undergo a little bit of change. There's an increase in cortisol levels due to increase in estrogen. And this increase in cortisol levels are really thought to be needed to maintain homeostasis and help prepare the body for the stress of the pregnancy, stress of delivery, and then ultimately lactation. Unfortunately, the increase in cortisol levels also contribute or attribute to insulin resistance and the development of striae, which are those stress marks. So insulin resistance, diabetes, and then the striae. Um, Elevated androgens typically occur. Elevated androgens, we're not really completely understood, but we do know they're thought to play a role in maintaining the pregnancy and ultimately initiating labor. Okay, we've got some breast changes that we're going to see. We've already talked about where the areola gets darkening, the nipple tips to get bigger as well. And this often occurs even a couple weeks before becoming pregnant. And many women would notice or being diagnosed with pregnancy. A lot of them will come in complaining of breast tenderness and breast enlargement, increase in size, and say, I think I'm pregnant because I had this happen before. Changes in the size of the areola, and definitely after that second month, we see visible changes of the skin. Nipples increase in size, we have darker pigmentation of the nipple and the areola. Okay. After the first few months, we have the development of colostrum. So colostrum is thick fluid that can oftentimes be expressed from the nipples. This is not necessarily uh, milk. I mean, there's a degree of milk, a form of milk, but it's really from an increase in the estrogen level. Okay? Again, areola changes, and then a lot of times these patients will develop changes not just in the color of the areola, but around in the side of the areola, there's these glands of Montgomery. And when you look at it, it'll look like a whole bunch of kind of pimples in around the areola. That is just the glands of Montgomery that are enlarging due to the pregnancy. Completely benign. It's not going to affect the pregnancy. It's not going to affect the ability to breastfeed. They're just normal responses in pregnancy. And a lot of patients will come in concerned about those changes, and so reassurance is just needed. And we've got some hematologic changes. Oftentimes we'll get a slight leukocytosis. We've got a slight increase in our H&H, and all of this is because we have an increase in blood volume by upwards of 50% very early on, starting as early as 6 weeks. But this is a hyper dilution. This is really just where we have increased circulating volume. It's more water in the blood, right? And so we're diluting with a hypervolemia, we're kind of diluting that blood. So because this is a dilutional blood, or thinner blood, platelet counts will actually decrease because of that, right? We do have an increase in RBC volume, and then iron requirements are going to increase overall. Okay, so 50% for red blood cells, 30% is going to go to the fetus, and then 20% is for maternal. Again, another reason why iron supplementation is important while we take prenatal vitamins. VTE risk 5 times higher in pregnant women, and even more so in the immediate postpartum state. Okay? That's due to increase in estrogen, decrease in fibrinolysis, and then an increase in stasis on the vasculature. Pregnancy is a constant inflammatory state of pregnancy. So we have increase in inflammatory markers, really no evidence of associated underlying pathology, but this just happens because we have a constant inflammatory state, which makes it really important because we need, patients come in again, they're complaining of, I think I have an infection, so we're doing ESR or CRP. In a pregnant patient, we expect those to be increased. So we may not be able to use those labs. D-dimer is really important because we use D-dimer a lot, or some people do anyway. We use it outside of pregnancy, but in the pregnancy state, we expect the D-dimer to be elevated. And if you guys remember that D-dimer is used for us to identify if we think somebody has a DVT or PE. And if it's elevated outside of pregnancy, then they get a study of choice, either ultrasound or CT, pulmonary embolism, to evaluate for that. But in pregnancy, the D-dimer is elevated anyway, so you can't really use that as a diagnostic tool or a screening tool to help us with the diagnosis. Right, to compensate for that increase in blood volume, the spleen enlarges by about 50%, and that occurs early on in pregnancy, usually during that first trimester. This increases the chance then of splenic rupture, even in mild abdominal trauma. So someone in a mild fender bender, but the steering wheel hit their abdomen, increased risk of splenic rupture. So I would definitely know that. And of course, if they have any trauma in that third trimester, these patients are going to be monitored very closely because of that increased risk. All right, we talked previously about dental being a part of the first trimester evaluations, right? And during pregnancy, we've got those hormonal changes that increases the acidity in the mouth, leading to increase in cavities, which is why dental hygiene, as we discussed previously, is really important. Okay? Oftentimes, this can be due to an increase in sugar intake from cravings, but sometimes it's also due to a decrease in attention to dental care. So it's really important that, even though we expect our dentist, the patient's dentist to do this, we will encourage them for appropriate dental care as well. But the ligaments and the bones in the mouth, they actually may loosen temporarily during pregnancy, and the teeth can wiggle a little bit. Okay, it doesn't increase tooth loss, but these patients may come in and say, like, my tooth is loose and it's never dangerous. Okay, we want to just kind of encourage them, probably don't bite on a bunch of really hard stuff, apples, steaks, but ultimately, as long as they take care of their teeth, we don't have any significant long-term complications. Right? Particularly in the third trimester, the body's inflammatory response will increase the amount of bacteria and plaque that stick to the teeth. So we oftentimes will see more gingivitis in that third trimester than we see in earlier. And again, more commonly due to hormone changes, sometimes due to local trauma, pregnant women can develop things like pyogenic granulomas, and I'm not sure if you guys have learned about that in dermatology yet, but they can get these pyogenic granulomas of the skin or of the gums, and these are benign, but they bleed like stink. Okay? They bleed so bad. So when these patients come in and they have these pyogenic granulomas, we just try to talk to them about avoiding trauma to that area. And as the pregnancy, after delivery, that the pyogenic granuloma will go away without specific intervention. But a lot of times we just kind of leave these alone, otherwise they bleed tremendously. Pretty common in pregnancy. All right. like to say, who knew about this? As probably women who have been pregnant knew, but yes, memory loss or memory does decline in pregnancy, most notably in that third trimester. And it's quantified really as a decrease most of the time in verbal recall. And I talk to you guys about that all the time. Like words matter, but I just can't come up with words. That's postmenopausal. The same thing happens in pregnant women. Okay? They have a decrease in recall, decrease even in reduction of speaking speed. Okay? Uh, these symptoms actually, even though sleep deprivation is certainly a thing, which we'll talk about on the next slide, but these symptoms don't even seem to be attributed to sleep deprivation. Don't seem to be attributed to anxiety or depression or any other physiologic changes in pregnancy. So distinctly, they just have memory changes. These are not permanent. They resolve pretty quickly after delivery. But the point is, don't beat up on someone in their third trimester. You'd be like, we just talked about that. Don't you remember? Actually, I don't. It's not my fault. The literature says I don't remember things, right? Um, Ocular changes can occur, right? Ocular changes. You have decrease in vitreous outflow results in decrease in intraocular pressure. The thickness of the cornea can increase, and this can actually lead to poorly fitting contacts, right? And that's due to edema of the cornea. Overall, the vision itself doesn't seem to change, okay? And those ocular changes will resolve shortly after delivery. But if they come into you and they're like, my contacts just don't seem to be fitting very well. Previously they were fitting fine, but they don't seem to be fitting very well. It could be directly related to pregnancy because ocular changes do occur, but the vision itself remains unaffected. And again, improves, all those changes improve after delivery. And finally, we're going to talk about sleep. Sleep is good for everyone. You guys probably don't know that, but you will pretty soon. Yay. Okay, but by the time a person is about 12 weeks pregnant, they're already significantly sleep deprived, okay, and there are changes in their sleep patterns. These changes often continue through the pregnancy and even into the postpartum period. Women have difficulty falling asleep, they have difficulty staying asleep, and in general, they have poor quality sleep. If someone's not sleeping well, we got to be extra concerned because if they're not sleeping well, they're probably not eating well. They probably are having more episodes of anxiety. They're going to be at increase for depression during the pregnancy and postpartum depression as well. So sleep deprivation and psych tend to go hand in hand. And so we want to talk to our moms about sleeping and the importance of sleeping and sleeping on their sides and not on their back. Okay. All right, folks, that is it for today. Hope you guys have a good weekend, and I will see you later.